I get the bad title. So my disclosures are over here. David took great pains to say, talk about the science, don't talk about me. So of course we haven't mentioned him at all. And I'm going to talk about the pharmacology of compartments. And really, in a sense, the work that we've done, the work that David's led, has been very much part of an international effort, which has involved Angela and Courtney and Pete Anderson and so many other friends at this meeting. So, first of all, when people talk, it's important to define what you mean when you use the words like reservoir and sanctuary and persistence. Some people take that to mean one particular cell, central memory T cells, long-lived. Other people take it to be one particular compartment, only anatomical compartments. So for the purpose of this talk, I am going to talk about reservoirs primarily as being in cells, because that's where HIV replicates and that's where it persists. And the reason that it does so is either to do with the biology of the cell or the cell-virus relationship, or else it's to do with the location of the cell. The cell is sitting somewhere that makes it relatively inaccessible as far as the drug is concerned. And the consequences of having sanctuaries are obvious, and we've talked about them today in terms of whether it's a barrier to cure or it's persistent inflammation driving aging, driving cancers and comorbidities and transmission and the rest of it. So if you think about HIV as in anatomical compartments, then there's some interesting data. So these are immunopet images of monkeys, of primate experiments, looking at the anatomical location of HIV. And the usual suspects are there. It's present in lymph glands, it's present in liver and spleen, and GALT, abundantly in GALT, and also, interestingly, nasal-associated lymphoid tissue, which seems to come out as quite a hotspot. You can map these imaging findings to actual immunohistochemistry. And you can look at quantitative amounts. If you look then at these primates which are treated and with antiviral therapy, then actually you can see that although the viral load goes down, these sites by and large still persist. And in certain elite controller monkeys, you see pretty much the same thing. Okay, so you can think of sanctuaries as being in those anatomical compartments. But as I said to you, it primarily resides in cells. So I think a more useful way to look at it is in this review by Tae-Wook Chun in Nature Immunology, where you think of them as cells in body compartments. So there's a whole array of GALT, nasal lymphoid tissue, spleen, brain, and other your pet organ, testes as well. Cell types, and so it's important to know when we think about flushing out reservoirs, not just central memory T cells with HDAC inhibitors, what's that doing to macrophages? What's that doing to stem cells? All these other potential reservoirs. We look at the state of the virus, so that's the biology, and the status of the infected cells. And really, I guess the question to ask, the really important question here is, why? Why? Is it because there's not enough drug getting into the compartment? If we let the drug get in there, it will do everything. Or is it actually that there is a natural ceiling of activity for heart for which we have nearly reached? So I think that's not quite resolved. It's not a either-or situation. These are data that most people here will be familiar with. Courtney's, I think, very important work looking, and we talked about it earlier today, looking at the different difference from PBMCs in tissues of these different drugs, tenofovir, FTC, atazanavir, showing that they differ by location, and even within the gut they differ by location. And so that's the pharmacokinetics. The pharmacodynamics, clearly there's a very wide difference in the way people respond to treatment. So you get people who, these are immunohistochemistry from follicular dendritic cells, and you can see some people seem to eliminate HIV much more effectively than others. And so this was a paper that actually did map down the importance of getting appropriate drugs in the site of tissue, something that we'd all instinctively thought, and here was some good evidence. And some of this work's been extended recently in 3 individuals, and really, quite interestingly, suggests that the virus does compartmentalize. So you've got plasma in green, lymph node, and PBMCs. And you can see PBMCs are seem to traffic in and out of these tissue compartments and carry with them some evidence of virus, some viral footprint, if you like, but that there's continued evolution with little apparent selection pressure for resistance. So why aren't these viruses, these gag sequences that you're mapping, why are they continuing to evolve in the presence of apparently suppressive heart? So here's a patient that I discussed with David. It was a headache of mine, okay? And this is not one of my successes, so please don't show this slide around. So I was sent this patient way back in 2001 as a patient who had extensive exposure to nucleosides, a whole array, and some NNRTIs had failed, and had a lot of TAMs. You can see extensive TAMs, L74V, 184V, so blown a lot of nucleosides and NNRTIs. We didn't know this at the time, but I put him on a lopinavir regimen. He suppressed. Then we got these tests, and then, as was common at the time, we said, well, the nucleosides have very little activity, half a drug out of tenofovir, can't use any NNRTIs, so let's give him 2 protease inhibitors. And he suppressed. And I thought I had done rather well with a rather difficult situation. And then subsequently, he rebounded, and he had raltegravir and darunavir, and then he suppressed, and then he began to have continued low-level viremia. We did everything. We did adherence testing. We did low-level viral genotyping. We did drug levels, a lot of it, okay? But he continued to blip. And then we enrolled him in a trial of research lumbar punctures. And this was his CSF. So his CSF did not resemble his plasma resistance. This CSF almost exactly mimicked the virus that I thought I'd got rid of in 2001. So in 2001, this guy spread HIV all over his body. I drove the plasma HIV underground, but in his brain, this continued to replicate and continued to evolve. And so in that knowledge, we changed his treatment. We added Maraviroc, even though there was a suggestion he might not work, but Maraviroc was primarily to target microglial cells, and he suppressed, and incidentally, there was some subjective improvement in CNS. But this, I guess, is what people call spatial monotherapy, isn't it? That certain compartments see, maybe not all these drugs. These drugs that I put him on were actually pretty low CPE score drugs, if you believe in that. So what about that research study? And David was involved in this study, involved in the design and the articulating the questions that we wanted to ask. And so we took people who were long-term suppressed, and we looked at their CSF. And then we took people who were persistent low-level viremics or blippers, and we did their CSF. And there was no indication to do a lumbar puncture. We found that 1 in 5 patients who blipped or had low-level viremia had a CSF viral escape. That's to say, a CSF of half a log or greater. And if you look at these people, the B are people who have viral escape in the CSF, and the A's are people who don't. And you can see that there's a whole gamut of inflammatory cytokines and markers of neuronal damage. So this is probably not a good thing for the brain. As part of this study, we looked at efavirenz, and so again, David was part of this. We looked at the efavirenz concentrations in the plasma, and of course, you see this unsurprising pharmacogenetic effect. And if you look at the efavirenz concentrations in CSF, the same thing, so the same CSF drug exposure according to genotype was seen. And if you look at the 8-hydroxyefavirenz concentration, which is the metabolite that's produced by 2B6, then that was also detected in the CSF. Now, 2 very interesting things came out of that. One was that 90% at least of that 8-hydroxyefavirenz in the CSF was glucuronidated. We hadn't expected glucuronide to actually cross the blood-brain barrier. So the question is this being produced in the brain? Is the brain metabolizing drugs and glucuronization it? Secondly is that, and then we compared this with a cohort of people with TB meningitis in Vietnam. Again, the same thing in plasma and CSF, and the same 8-hydroxy. But these people had very leaky blood-brain barriers, so perturbed CSF plasma albumin ratios. And some of these were comatose, and mortality in this study was pretty high. And again, very high levels of 8-hydroxyefavirenz in these patients. And I think there's some in vitro data suggesting that 8-hydroxyefavirenz is actually much more neurotoxic than actual parent. So this is one study looking at dissected rat neurons, and whether you look at calcium signaling or neuronal apoptosis or the architecture, the dendritic spines in neurons, you can see that the 8-hydroxy seems to have the most destructive effect. So the question is intracellular metabolism of efavirenz a good thing or a bad thing? And what happens when you have TB meningitis and you leak a lot of 8-hydroxy in? The brain, of course, is also metabolically active, and I think you've heard a little bit about tissue metabolism of drug, and there's certainly plenty of brain 2b6 if you care to look for it. If we go on to the genital tract, which is another compartment. Again, David has done some work in it, and many other contributors, including, of course, Andrew Kashuba's group. And you can see that there are class-specific effects, but within the class there are there's a hierarchy of drug accumulation as well. And there's some work from Courtney's group looking at the metabolism of drugs within the sanctuary site. So within testicular tissue, this is an array of 10 transporters and 2 cytochrome P450s. And if you look at the stain, the blue stain is DAPI, so that's a DNA stain. It stains for nuclei. The red stain is an ATPase, that stains for cell membranes. And you can see that cell membrane localization with the transporter or the CYP in question is present abundantly in some cases. So certainly the metabolism of drugs within a sanctuary site probably contributes negligible amounts to the plasma PK compared to the abundance of 3A4 in the liver, for example. The testicle doesn't count for much. But in terms of the actual relevance to the site itself, it may well be far more significant. What about breast milk? So I think Andrew has shown some data. These are data from Tanzania in the pre-B+ regimen when mothers were breastfeeding but not covered by HART. So this was a study, an old study in Tanzania actually looking at vitamin supplementation. And there were some transmissions, 61 transmissions, unfortunately. And so they did phylogenetic sequencing on the infected infants. And they tried to map this to either maternal DNA, in other words, or maternal RNA in breast milk. So the question is, was this cell-free transmission or was this cell-to-cell transmission? And I think the data were interesting. What they called early transmission, less than 9 months, seemed to be associated with cell-associated virus. So cell-to-cell transmission seems to be associated with early transmissions, or the converse, early transmission cell-to-cell. Whereas later transmissions, there was an equal contribution of both. And I think that gives us an interesting insight as to why there is persistent HIV. And we'll talk a little bit about cell-to-cell transmission later. The same French group looked at T cells within, so breast milk is of course rich. There's a lipid fraction, there's an aqueous fraction, there's a cell fraction, and the cell fraction is rich in macrophages and T cells, and the T cells are very likely to be activated memory cells, and more recent data suggests they have mucosal homing markers. So really, this is a high. If they're Trojan horses carrying HIV, then this is a worry for breastfed infants who are not covered by antiviral therapy. And you can see that even in aviremia, even in suppressed patients, if you get these T cells out, they will spontaneously produce antigens. So another situation, seemingly suppressive heart, and yet you can tease out HIV without trying particularly hard. The question of whether breast milk macrophages play a part, I'm sure they do, is an interesting one. Okay, so Katrina Waite, one of David's protégés, and currently now working with Mohammed, did this systematic review and meta-analysis, trying to summarize all the data about breast milk penetration of ARVs. And And although there's much variability, and of course the methodology for breast milk concentration is very variable, in fact, and the extraction procedures are a nightmare. You can see that in general, NRTIs, as they do with every compartment, which is why I'm a great believer in NRTIs, and I'm a slight worrier about NRTI-free regimens, NRTIs seem to get across much better than NNRTIs or PIs. Andrew's spoken about this, and I think he's effectively said that we see this pharmacogenetic effect in maternal plasma, maternal breast milk, and infant exposures. And of course, the baby gets 2 hits. They get more efavirenz from a poor metabolizer mother, and they also get the genes. So no wonder exposures in neonates with efavirenz approaches therapeutic concentrations for some of them. And of course, this was never worked out when B+ was implemented, but there were other overriding priorities at the time. Just another tissue, and there's interest in the lung now because of the big rise in chronic lung disease, very aggressive emphysema that you see, recurrent bacterial infections, which I think Moha will talk about. But this is work from Malawi, where they do research bronchoscopies on HIV patients. So they pull out all the alveolar macrophages and they sort them out. And the small alveolar macrophages seem to be preferentially affected. And they're infected with HIV and they're affected. So if you look at superoxide burst or bulk proteolysis or phagocytosis, there is a defect in their function. And if you look at these patients, this work's been extended. If you look at this patient in, again, apparently suppressive heart, you can see that actually there is still HIV persistence within alveolar macrophages. Now, I'm not saying the lung, which is a very vascular organ, is a sanctuary site, but I'm saying that the breast milk and the lung are very good places to get a window on what's happening in the tissue, and particularly the tissue macrophages, which I think is something that we do need to think about. So why macrophages? They're a primary tissue reservoir of HIV. They're long-lived. They're less prone to cytopathic effect. They have less DNTP pools. So potentially the nucleoside could outcompete them in these cells. There's TK1 in lymphocytes, TK2 in macrophages. There's host restriction factors which are enriched. So SAMHD1, ApoBec, TRIM5-alpha. These things are abundantly present in macrophages. And there's work done by people here and Carlo Federico Perno as well, looking at EC50s of nucleosides, nucleotides in chronic and acutely affected macrophages, suggesting there are differences. So, and to finish off with, I think we talked about cell-to-cell transmission. Of course, cell-to-cell transmission is a delivery of a neat, big dose in a tiny package at a local point on the membrane, and actually the drugs may not be quite so effective. There may be differential drug activity. This is a debate that will go on and on. There are believers, there are non-believers, and there are people who just don't know what to think, like myself. So, I will finish with this fact that we need to take an Olympian leap, and this is a picture of a young David back in the 1968 Olympics. I had some even more embarrassing photographs, but I had my arm twisted. And I think that there's a sense in which modern heart does not fully control HIV replication. I think we'll all accept that. There's a sense in which it could be further optimized by better delivery into compartments, and I think that nanoformulations offers maybe one of the best opportunities for trying to do that. I am a great believer in the utility of NRTIs, but I think that there are a lot of unanswered questions, and I think that David has certainly perceived that this is the case, and the kind of work that's been happening in Liverpool has evolved very much around that picture. So why the hippopotamus? This was nothing to do with David, actually. But my African friends tell me that you don't in Africa say the tip of the iceberg, you say the eyes of a hippopotamus. And so when the eyes of the hippopotamus are what we call the viral load, but of course there's a huge a rump, a backside, if you like, of compartments that deal with macrophages, with tissue compartments, and that these are things that still causes problems, whether it's a barrier to cure, whether it's this persistent immune activation that we still see, whether it's low-level viremias, which are effectively a spillover. Low-level viremias are a spillover that just pop up every now and then above the waterline. And I will stop there. Thank you.